Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with JR. How are you doing today?
I'm great, Dennis. Thanks so much for having me back on the show.
I really appreciate it. So you did a presentation at SOMSA 25 here in Raleigh this last year, and it was on end-of-life care, and I didn't get to see it. So I begged you to come on, and you relented. So I guess, why did you pick, of all the things we could talk about, why on earth would you have picked end-of-life care?
Well, I think that I think we're seeing a national conversation more about end-of-life care in general with patients in our civilian healthcare system, and including patients in their decision-making about how aggressive we want to be with care and how people want to spend their last few days. But we have had so few conversations about that when it comes to combat casualties. And when it comes to the patient who has a sudden medical issue or trauma that is not survivable, we tend not to really head that palliative care direction until things are so obviously past the point of futility that we can finally say it. But we're not having those conversations right now about palliative care in the military setting. And I think that as we look at our next conflicts, if we look at the large-scale combat operations and also the environments that we're operating in right now with the IWUW environment, that palliative care is just it's a big blind spot for us, and we need to start this conversation. We're of course working on palliative care guidelines for prolonged casualty care, but this conversation, rather than detailing exactly what to do with palliative care, what I want to talk about is how do we arrive at this decision to not aggressively treat the patient, to not burn resources on the patient, to burn our blood supply and our surgical team and so forth in a futile attempt to resuscitate a patient who in this environment will not survive.
Yeah, I mean, that makes sense. And this is a really, really difficult kind of question. Obviously, everybody knows, and it's repeated almost daily. Hey, in war, like, people die. Understood. However, 99.9% of all my training lanes, it turns out that that's not true. They always live, and which makes me feel great. But I don't think it necessarily prepares me for reality of things, that you can actually do all the things well, and the outcomes are still not great. So I guess my first question is, like, how about step back? Like EMT training, they tell you how to recognize death. Like, and there are always the blatantly obvious ones, like rigor mortis has set in, decapitation. I think I can spot those things. And even in combat, somebody's got a, traumatic brain injury from a GSW, like through their head, or a great vessel injury that cannot be stopped. Those are pretty obvious, and usually they kind of determine the outcome pretty quickly. I'm wondering, how on earth am I supposed to know this guy's going to die if I've done the things and he is kind of eking along and we're putting more resources, and it feels like if I just did this one more thing, everything would be great. And you're telling me I need to declare him done.
Well, we're not going to declare him done yet if he's still alive. But you have an opportunity where you can refocus your efforts on managing pain, managing anxiety, not aggressively resuscitating, but instead to focus on the patient's comfort. We hear this a lot, like when you're doing EMS training, that DNR doesn't mean do not treat. And same thing, anybody who's experiencing end of life, it doesn't mean we just send them off to a corner to die alone or anything like that. But you're absolutely right that the obvious ones are not a tough question, right? The decapitation, hemisection, incineration, they've got rigor, they've got lividity, those things. As you said, an EMT can make that decision. That's not a hard decision. But let me put you into a mindset here. You've got a U.S. casualty, so Special Forces ODA member, who experienced blast trauma, right? So close to a IED, maybe victim initiated, and you've got amputation of the right arm, of the elbow. You've got a partial amputation of the right leg, multiple puncture wounds to the torso. And you do all of the T-TRIC things when at the point of injury. So you stop the bleeding, you seal the chest wounds, you decompress as you need to, you secure the airway with the surgical crike. All the right things that you're supposed to do. He's got a heart rate of 160. The blood pressure that when you get a reading is 68/30. His SpO2 is not registering because the perfusion is so poor. He's so clamped down that your SpO2 can't register. So we take him to the operating room. So we've got our small forward surgical team, or the ghost team, or the SOST that puts him on the OR table right away, and a skilled bunch of surgeons and nurses, medical providers that are there. We give 4 units of whole blood. He's got simple thoracostomies. Open the belly, pack the belly on the 4 corners. We find there's a complex hepatic wound. The superior mesenteric artery is torn off its vascular pedicle, and this patient is really sick. A very, very complex wound set here in this setting, and the context that I have for this because we do this exercise in West Virginia called Ridge Healer, where we take these very small footprint surgical teams, and after some classroom and some preparation, we infiltrate into these sites in West Virginia, these barns and mines and empty warehouses and so forth, and set up our small surgical resources and throw casualties at them for several days. And so they have to do the PCC, and they have to do the operative management, and they have to go pick up casualties during their point of injury care and so forth. And we get to see some patterns that come with this. And this type of injury is a problem I certainly throw at them. You mentioned this training scar that all of your patients live in training. So I like to give them patients that will challenge that thought process, because maybe you do everything right and the patient doesn't live. So what do we hear from them on this? We hear them say, well, of course we're going to do everything, right? We're not giving up on one of our own. Well, we have to look like we're doing something. So this is an ODA member. So the rest of his ODA has to see that we're doing everything. You got to see that we're doing something here. We're putting on a show for the team so that they know that we did everything, and they can see that everything was done to try to save his life, and he still didn't survive this terrible, terrible injury that he had. But I think that we're being very myopic in that resuscitation, in burning those resources on this casualty, because as I talked about here, this initial laparotomy and initial resuscitation of the 4 units of whole blood, that's just the start of what this casualty is going to need. And it's going to need pretty extensive surgery, multiple surgeries, a lot more volume resuscitation with blood. And so let's talk about the risks of this resuscitation in an irregular warfare environment, even a LISCO environment here as well. So what are the benefits of doing this? One, we're demonstrating our capability of the team. So to our teammates, we're showing that the surgical team is extremely good at what they do, and can do it quickly, efficiently, and well. So those fighters have the confidence that excellent medical care awaits them in this environment should something bad happen to them. It gives us an opportunity to practicing frequent skills, because as any surgical team will tell you, most of the time that you're deployed, you're not seeing badly injured casualties. You're not practicing those trauma resuscitations and trauma surgeries. And a couple of the more intangible benefits are that we're giving the team time to accept death. We're giving them time to arrive at that conclusion on their own and see that, everything that we're doing is going the wrong direction. This patient is continuing to deteriorate despite very aggressive care. Because it's a tough thing. Like here, you're talking with your buddy on a patrol, and then next thing you know, he's comatose and badly hurt, and then you're not talking to him again. So he's going from alive and perfectly healthy and full of humor and life, etc., to dead or dying in a very sudden period of time. And so having that resuscitation kind of gives folks time for their brain to wrap around it. And this is something that I've seen in a lot of resuscitations, particularly pediatric patients who suffer cardiac arrest or drowning or severe trauma, that those attempts at resuscitation give the family time to wrap their mind around the fact that their child is not going to survive. And then also to erase lingering doubts among the medical providers. You mentioned this moral injury that occurs, the medic who is asking themselves, did I really do everything? Is there a chance that somebody could have been saved, that this guy could have been saved? Had I done more? Had I done something differently? And we hear about these heroic resuscitations where a casualty there was a ranger who received something like 300 units of blood and survived and to a good outcome. And certainly those are out there, but as we say in medicine, these are zebras, right? You hear hoofbeats, you think horses, not zebras. Those are zebras. Those are extreme outliers. And we have to realize the environment that they're in when that occurred. This is in a setting where we had extremely robust medical resources, very rapid transport to definitive surgical care, to resuscitative surgical care, and then definitive surgical care, and lots and lots of blood. So we had all the resources. And I think that this is where our experience comes from in the civilian setting, is that in the hospital where we do all these heroic attempts at resuscitation, because we're flush with resources, like that's easy. This is not the environment that we are encountering currently in the theaters that we're working in, and it's not the environment we're going to encounter when we go toe to toe with a peer adversary either. Now we think about the costs of this resuscitation in that IDW environment. One, we're going to burn supplies, and our logistical chain is not robust enough for us to just keep throwing all of these things at a patient and expect to remain combat effective, and for our surgical team to remain surgically effective for follow-on casualties. There is the matter of team fatigue that when you're working on this casualty and for hours and hours and hours and hours, and you're flipping your day-night cycle because you maybe have only one surgeon that can do these operations, is driving that surgical care, that wears on you after a bit. Remember, we're living in this environment there, and we have to remain ready 24/7 in that setting. We don't have shifts so much, so you're really working hard on this casualty for many, many hours is going to fatigue the team. And that's going to not only decrease our ability to function, but that also affects our ability to process emotionally trying things, and our ability to decrease that PTSD, that moral injury, those things. We're going to draw attention from other casualties. So, particularly when you've got, hey, this is a U.S. casualty and these are partner force casualties and we're a U.S. team, that's certainly not doctrinal to do that. We should be caring for folks based on the severities of their injuries, but it is still going, even with that proper triage, this casualty is seriously injured. It's going to draw a lot of attention and a lot of resources. And when you've got a limited medical resource, that's tough. You're obviously stressing the logistics chain. In the irregular warfare or unconventional warfare environment, the problem with that is every time you activate that logistics chain, you're increasing your profile and increasing the chances of detection. And so you want to be thoughtful about that, because eventually the enemy is going to figure out, hey, there's, like bringing all this stuff to this location. I wonder what's there, right? We're diminishing our capability when we use up all of our expendables, our blood, our dressings, our medications, those things. We're diminishing our ability to care for casualties that follow on. And there's also this moral injury of the futile effort. And I'm sure that you have, as I have, been involved in resuscitations that were clearly futile from the outset. And I've got terrific nurses and paramedics and residents that may say kind of quietly, "Hey, what are we doing here? Like, what? Why are we continuing to do this?" And we're spinning our wheels, trying to make a show for somebody we know is not going to survive. And we may be doing things to them that are terribly painful, whether they're awake to experience that pain and express it or not. So we have to be thoughtful about what do we have in this IW setting? What do we have to offer? We have damage control surgery, so stop the bleeding, shut the arteries, restore some physiology. We have a limited resuscitative capability, so and this is going to vary from team to team, environment to environment, but we only have so much blood, and it may not be readily available to us, even if we have taken the time to build out this robust Rolo program among our partner force and maybe villagers and other folks that are supporting this effort, this operation. We have some infection control ability, although operating in this environment, doing surgery in this environment is not sterile, it's not clean the way it would be in a first world hospital, but we have the ability to wash out dirt and pus and give antibiotics and so forth. We can do wound excision, as Jason Hiles said on your previous episode here, like don't leave dead tissue in the wound. That only serves to be a nidus for infection. But what don't we have? We don't have lots of blood and fluids. We can't easily replenish our supplies. We can't hold them for a long period of time. Casualties crush momentum. They halt movement. They significantly slow movement. And if you are in an asymmetrical warfare setting, then having that litter-bound casualty is going to slow you down significantly and potentially increase the chances that you're discovered or captured. We don't have good access to neurosurgery in this setting. Neurosurgery is a precious resource. Renal replacement therapy. There are some improvised dialysis techniques that can be used, but you can do some improvised peritoneal dialysis, but that's not going to be very effective in that early setting until the peritoneum kind of gets used to it. And so basically, we can't do renal replacement therapy in this setting. Intracranial pressure monitoring, I don't know how useful that is in this setting. Now, and I'm talking about the semi-permissive or denied environment. Let's talk about like just that large-scale combat operation and look at a historical example, the Battle of the Bulge. That was 41 days long. They had 19,000 killed, 47,500 wounded. If you took that number of casualties and dropped it on the U.S. trauma system right now, then it would be strained to take care of that, much less in that smaller environment deployed overseas. And we don't have the medical resources that can efficiently care for all of those casualties to the standard that we do, or that we've come to expect through OIF and OEF and through our civilian experience as well. So what's non-survivable? You talked about the things that are the obvious sign of fatality, that we don't attempt resuscitation. You mentioned one of them, so transtentorial penetrating injury. So if you have a GSW that crosses the midline, that's 100% fatal. They will die as a matter of certainty. The patients after blast injury who are not breathing, they also will die. Now, I'm not talking about that initial, what we call impact apnea. So somebody experiences that blast injury. They may, for a couple of minutes, stop breathing, but then that breathing starts up again. But if they are not breathing like continuously after that blast injury, that's not survivable. Penetrating two walls of the myocardium. So if you have a piece of shrapnel that punches through two walls of the ventricle, we can't fix that, because the way to fix that, you have to put somebody on cardiopulmonary bypass, and we don't have that capability in a combat setting. Some other things to consider: dividing the pancreas. We do not do Whipple procedures in this combat setting. So the surgical sole, which is right in that area, a lot of vascular stuff. You've got your hypogastric and your celiac trunk and your pancreas, and a lot of vascular stuff right in that area, right where the pancreas comes in, meets the liver and the aorta and so forth. Really complex hepatic and portal injury just requires a lot of surgical resources there. Now, I'm going to give a caveat here, is that I am not a surgeon, so I'm not going to tell my surgical colleague, like, yeah, you can't operate on that, right? Experience and resources is going to vary from place to place, but talking with a lot of my surgical colleagues, generally agree that in the setting that we have here, these are not going to be survivable injuries over the long term. Refractory shock, refractory metabolic derangement. So you have shock that's just not turning around with early resuscitation with blood products, or persistent metabolic acidosis that's really, despite volume resuscitation, even giving some bicarb or THAM or whatever you need to do to try to fix that. And if it's not working, then that may be an indication that this is not survivable in that setting. The divided pancreas, like, they will potentially survive the initial injury, but they will die within the next 2 weeks. So again, we're looking more long term for that. Some other things of consideration here: if you've got hepatic injury with a retrohepatic or portal uncontrolled hemorrhage, that is extremely difficult to manage, even in a robust first world surgical setting. And now, a single injury to a big vessel is probably repairable, but if you lose a segment of a big vessel, I'm talking named vessels, or devascularizing the mesenteric vessels, those are probably not survivable in this setting. We don't have the ability to shunt adequately, but more importantly, to volume resuscitate them adequately while we repair that problem. Thoracic aortic disruption is probably not survivable. Maybe a tiny laceration if you're not hitting any of the branch vessels, maybe. But for the most part, if you're taking out the aorta then in the chest, then it's not going to work. Really, is it the hepatic injury, retrohepatic, the devastation of the right upper quadrant? That's going to be just to require way too many resources to fix. That surgical sole, which includes the duodenal, retroperitoneal, pancreatic head, IVC area. That's what we're talking about with that right upper quadrant. Just extremely difficult to manage. Penetrating head trauma with a GCS of less than 6, then that portends a devastating head injury. And we have to think not only about, like, what can we do right here? Where are they going to be going? Now we think about our U.S. casualties, that we're going to take care of them. They're going to go to a role 3, role 4, and have pretty robust resources, but it's going to take us a while to get them there potentially. And if it takes us a week to get them to launch stool, then in the meantime, there is a lot of opportunities for them to die. But if this is a host or partner force casualty, and we're going to push them back into that guerrilla medical network, then it is extremely unlikely that they have an intensive care unit capability. So if the patient's on a ventilator, then they're just not going to survive when that occurs. Now, there is some data but very little data to help drive this. A couple studies out there, though, that help. For trauma patients, pH of less than 7, there was a study from Robertson et al. Showed only about half survived that initial resuscitation, and then maybe another third of those survived to discharge there. So, again, this is in a robust setting, in a first world level 1 trauma center kind of setting. What we find, though, is that if they have both coma and shock, then nobody survives. So from trauma, you have coma and shock, then they're not going to survive. Lactated pH are predictors, but only about 77% of the time. So there are survivors, but again, that's in a first world setting. Bicarbonate level of 6 to 10 MEQs per liter initially. They've got about a 26% mortality versus patients with a bicarb above 10 that have like a 3% mortality in trauma. So that's not a predictor by itself, but it does kind of give you some idea of the odds that you're facing. Acute kidney injury as well. So when we look at burden of acute kidney injury and 90-day mortality on critically ill patients, this study from Wiersema, Eck, and Hapio et al. This was published in 2020. And basically what it showed is that if you have a high burden of acute kidney injury in the first 5 days, then that's a 43% mortality right there. Overall, acute kidney injury gives you about a 23% mortality in a well-resourced setting. But if you need dialysis in our setting, in our combat setting, after injury, then that really is a death knell for them. Burns, there are some studies on burn mortality in low resource settings, and in Cameroon and some other places. First, there are different scoring mechanisms for burns, and one study showed that from Salehi et al. That showed that the ABSI seemed to perform the best in that limited resource setting out of the various burn scoring systems. But that lethal area 50% is about 50% total body surface area. So if you got 50% burns, then you're looking at least 50% mortality in that setting. There's the Cameroonian experience. This is a little bit of an older study from the 90s, but if they had greater than 60% total burn BSA affected, then the survival was like 0.9%. So it's extremely unlikely with those bad burns in that limited resource setting. The other thing that you have to consider is what are the resources that I have available to me. So looking at burn fluid use. There is a small study from Mitchell et al. That it was a small study. It was adults only. About 45% were intubated, but the mean burn area on these casualties was 29%. Now remember, we're talking just second and third degree burns with this, but in the first 24 hours, they on average used 15.6 liters of IV fluid plus minus 8 liters. And then in the next 24 hours, averaged 9.4 liters plus minus 6 and a liter of colloid. So the question is, did you bring 25 to 40 liters of crystalloid IV fluid with you? If you're a small footprint team, probably not. If you're not able to, like, if you don't have a really good logistics chain, or you don't have the ability to manufacture IV crystalloids in the setting that you've got, then, and Ken, this is 29% TBSA. These are casualties that we fully expect to survive in a resource setting. And even in a limited resource setting, looking back at that Cameroonian experience, with that level, your survival is like 16%. So it's still pretty unlikely there. But now let's look at, man, how much stuff did we bring with us to take care of these patients?
Right. And a lot of this, I mean, just going through the list in my head, a lot of this you're not going to know. Like, you're not going to know that shrapnel took out the head of the pancreas, and that's going to take a while to die from that one. You have like you mentioned, a GSW that crosses, the midline. Like, that one's pretty easy to put your finger on. Like, that one's going to die. A great vessel injury, a named vessel injury, if you can't put a tourniquet on it or pack it hard enough, like they're probably going to die fairly quick. That will kind of determine itself. But like your pH, what's their lactate, what's their bicarb, I'm not going to know that. Not for quite a long time until we can get this guy moved back. So, I mean, not to I guess downplay the injuries that we've come through, but how am I going to know early that this is almost a waste of time? I have an aid bag. At best, I got 2 liters of fluid. Hopefully it's blood. We have a day's patrol to get back to camp where I have another, maybe 6 liters. 10. Let's say, screw it. We got 20 liters. Like, we just got a resupply. I still don't have enough.
No, you don't. And in a lot of this data that I'm presenting here about various injuries, you're exactly right. Many of them you're not going to know until you open them up. Even if you're carrying an ultrasound, you're not necessarily going to know the extent of the vascular injury that you see in the abdomen, even if you are a fantastic ultrasound operator. But like you say, you can recognize the head wound, but the persistent shock. So you're on target and you've got this casualty and you've stopped the bleeding, but that you can, but you've got that internal bleeding and they're not improving with administration of a couple of units of blood. Now it's time for us to start thinking about, all right, can we, what more do we need to get this patient out of shock? I know we love permissive hypotension, but permissive hypotension over a long period of time, like the setting you're talking about with 24-hour evac, that is knocking down the kidneys, it's knocking down the liver, that's creating ARDS, those things. So for the medic, do I have something that's obviously not survivable, like that bilateral penetrating head injury? Do I have those penetrating abdominal injuries that they're just not improving at all, turning around with the limited amount of blood that I've given them? That initial resuscitation of maybe 2 units of blood. And I've given a lot of blood to people, and folks whose hemorrhage is controlled or even uncontrolled, you do briefly get response, and even a more prolonged good response with a relatively small amount of blood. See people turn around with a half unit of blood that were in pretty bad shock initially. So if you've dumped 2 units of blood into them and they're not turning around at all, then it is time for you to have a hard conversation with yourself as the medical provider to say, like, how long is it going to take us to get there? And can they even survive to that point? Am I going to be bringing them a corpse when I do? Or once they get there, what are they going to be able to do? Maybe this small footprint surgical team has only 4 units of blood, and they don't have much more than you did to start with. And I'm sure they can activate their Rolo and maybe get a few more units there. But this is where the conversation starts. This is where you start considering it, and when you start having that doubt, like, hey, what are we doing here? Can we consider discontinuing this resuscitation? Now, we have some data for like from EMS that patients who leave the scene of injury in arrest, they stay in arrest. They don't survive. So unless you do something heroic on scene, like some of the data from London where they have physicians that perform thoracotomies in the field, and then maybe there's some chance there. But if they are in arrest for more than 15 minutes from penetrating trauma, for more than 10 minutes from blunt trauma, then they are not going to survive. Now the question is, well, what's the risk? We can still like do the CPR and transport them and so forth, but consider the danger potentially to you, unsecured in the back of a vehicle as you're providing all the care. I tell the paramedics here, in a U.S. pre-hospital setting, like, hey, everybody's unsecured there. If you're driving lights and sirens through traffic, remember there's 10 serious injuries and 1 death in ambulance-related crashes every single week, and 2/3 of the people are not on the ambulance that are killed or injured. So we are a danger to the public, and we're a danger to ourselves as we're trying to do that. So we maybe have to thoughtfully take those risks or eschew those risks and say we're not going to take an unnecessary risk. What's a risk? Like, okay, yeah, we'll call in dust off here. It's a hot landing zone. Yeah, those helicopter pilots, they're fantastic, and they'll come in if you ask them to. But what happens if they take a round and now we lose an air crew and an airframe and all of this stuff? And again, if that patient wasn't going to survive, like, then we've just needlessly wasted lives.
Yeah. Yeah, absolutely. Absolutely. So, let's say we're even beginning to think this is not going to end well. Like, how do you, one, like, solidify your own decision and, like, stop the constant, like, well, if I just give them one more, or if I just do this next 47 things, to then, like, solidify the decision in my head so that I can turn around to the commander and be like, hey, this isn't going to go well. Like, we need to make a decision. Like, how does one even come to that?
Well, that first, the starting point is that as the medic, as the medical provider, or as the resuscitation team leader, you are the subject matter expert. And there's a certain amount of imposter syndrome that happens to all of us. And like, oh, yeah, I mean, yeah, but I'm just a medic. What if a doc has a different idea? Like, hey, you are the SME in that setting at that moment. And the ground force commander is looking for a recommendation from you based on your experience, your training, your knowledge that you have. So it has to start with courage. It has to start with leadership. And we love to kick the can down the road, to have somebody else have that conversation, have somebody else make that decision. But if we make this decision early on, then we can preserve resources, we can preserve capability, and we can also treat the patient compassionately in a way that they deserve, that, managing their pain, rather than torturing them with a whole bunch of stuff. So it starts with the courage, it starts with leadership, but also compassion, and which I know we all have, especially when it's somebody that maybe we've worked with, or it's a U.S. or partner force that we've gotten to know. And we are going to think about them, but we're going to think about them more holistically. That casualty would not tell you, yes, do everything you can on the very, very, very small chance that I'll get home again, and then not be able to take care of my buddy who gets wounded on the next patrol. So start there with that courage and have that conversation. So when talking to surgical teams, I say get the team medic on board. Get the 18 Delta that is embedded within that ODA that is trusted and has that strong relationship with them. Talk with them, get them in the right place. But then you pull the team leadership aside, the commanding officer, the NCOIC, the warrant, and have that small conversation with them that, look, this is what we're looking at, and free ourselves of the what ifs of, like, well, yeah, but I mean, what if maybe there was a small chance? I want to give them every shot that I can on this tiny chance. Like, realize that this is not OIF. Okay, this trauma didn't happen on the doorsteps of shock trauma in Baltimore. It didn't happen right outside of Carolinas Medical Center. This is happening here in this setting, and the hallway between this resuscitation bay and that intensive care unit is hundreds of miles and a very long period of time. So to start that conversation, like, if you know in your heart, like, this is a non-survivable injury, that makes it easy. If you don't really, it's still, you've got to make your best judgment call on that. And we fire the warning shot when having the conversation with that leadership team. He cannot survive this injury. That you and we gave him every possible chance to survive, but given the resources that we got and the nature of his injury and where this happened, he's not going to live. But the other piece is, it's not an either or. It's not like, resuscitate or dead. There is this transition in there, and that is where palliative care comes into the equation. That is where, when I'm making this decision to go towards palliative care, and we always want patients and family members, loved ones, to have some agency in the conversation if they've ever said anything, but that's not what we're talking about here. We're talking about a young, robust, healthy casualty that very suddenly suffered a catastrophic injury. We're going to focus on his comfort. We're going to focus on pain. We're going to focus on anxiety. We're going to treat these things as best we can to make him comfortable. And people always ask, like, well, can you hear me? I head that off. I say, look, I don't know if he can hear you, but I assume that he can. So please talk with him. Be present with him. That is okay. But when you have the medical personnel there, as you're discussing it, you all are on the same page, and then the leadership team, and you bring them in on that. And then when you have the broader discussion with the teammates, then they have an easier time accepting the terrible news that you're giving them at that time. And it's not we are giving up. It's we are shifting focus on what we are going to treat. Just like if we have a casualty with multiple injuries, so we can't manage all of them all at once. Okay, we're going to focus on this thing right now. In this case, we're focusing on these things right now: the pain, the breathing, the anxiety, all of that. There's a couple of important things to not say in that conversation. That absolutely never say. One is, we aren't going to treat this, or we aren't going to treat him. Okay, we are treating him. Even if that's a catastrophic hemorrhage and we're not going to be able to stop that hemorrhage, we're not treating it. It's just our priorities are not stopping the bleeding. Our priority is comfort. We never say if only. If only is the road to moral injury and post-traumatic stress and all of these things. Like, oh man, if only we'd got him here sooner. If only this. If only doesn't matter. It doesn't matter how we got here. The fact is, we are here. And so never say if only when having any of these conversations, not only with the patient's loved ones, but with yourself as well. We can certainly learn things as we consider and hot wash these casualties and think about the ways that we might change our approach in the future. But for this casualty, if only doesn't exist. And don't burden yourself with that.
So we mentioned give them opioids. In the CPG, the JTS CPG on analgesia and sedation has like an itty bitty little section on palliative care. And it mentions like morphine specifically, but it also mentions the options of hydromorphone or fentanyl or something like that. Does the analgesic matter? Like, why is morphine associated always with death? And I guess what makes opioids the magic drug for palliative care versus, like, I'm really used to using ketamine.
There's nothing wrong with ketamine in this setting, but a couple of considerations there. One, we love ketamine because it's relatively hemodynamically neutral, and that is why it's our kind of go-to analgesic in severe trauma. And we may not have that much ketamine, to be honest, and maybe it's something we can source easily locally. Maybe it isn't. Morphine is pretty widely available. We tend to steer away from morphine in seriously injured combat casualties because of the potential for blood pressure, a little dip in the blood pressure as we're giving it, as well as dip in respirations as we're giving it. The blood pressure I'm not worried about right now. And also importantly here, it is that effect on respirations that's beneficial in palliative care. You've got the pain that you've got to deal with but there is also the breathing difficulty. So if the patient feels like they're struggling for air, then opioids tend to attenuate that effect and make them more comfortable. So, morphine, Dilaudid, fentanyl. I love fentanyl. I don't necessarily love it for this particular case just because of the relatively short duration of action. So morphine and Dilaudid, morphine, 4-hour duration, Dilaudid 6-hour duration. So in your various nursing tasks that you're doing in this prolonged casualty care, it reduces that workload on the medic that is caring for somebody, making sure their pain is well controlled. But the breathing distress, the opioids can help with that. Also, benzodiazepines can help with that. So we frequently give in end-of-life care sublingual lorazepam for folks that are experiencing that anxiety and those breathing difficulties. We know from our experience in combat, combining opioids with benzodiazepines can potentially result in severe respiratory depression. But again, our focus here is primarily on the pain and the anxiety, the discomfort. So I'm willing to tolerate that potential risk. Right? We're not euthanizing this patient. That's not all the goal that we're trying to do, nor should we give somebody some morphine in this setting and then they die and then you're like, oh my God, I just killed this patient. Like, no, you didn't kill this patient. Okay. They died of their injury. And the proximity of when you gave pain medication, it really does not have to do with the outcome as far as their eventual death. It was the injury that did them in.
Because that's one thing as you're describing, dosing your opioids, like I wouldn't say it's a fine line, but it is almost semantics. I'm targeting a respiratory rate, roughly 20-ish. But every time I dose it, I notice his blood pressure comes down a little bit. And I dose him again and it comes down a little bit. Like to at least somebody who's not trained and somebody who isn't who fully understands this is why I'm doing this, it does kind of look a little bit like euthanasia.
It feels like that because you've got action consequence, right? You give the medicine, like you say, the blood pressure dips. That is okay. Dips in blood pressure are expected in palliative care. Dips in respirations are expected in palliative care. I don't want you awake and terrified and suffering because, I don't want to decrease your respirations, but by an expectable side effect of appropriate treatment for the condition. There's medical aid in dying is a whole different conversation. That's not where we're at right now with any of this. But for the medic, remind yourself we expect this. We expect some respiratory depression. We expect a little bit of hypotension. We're not accelerating this casualty's death. We're simply treating them. Same thing if you intubate somebody and they have a peri-intubation cardiac arrest, despite all of the appropriate setup and preparation and so forth, you didn't murder that patient. You didn't kill them. It's an expected consequence of the condition that they are in. Another thing to consider as well is secretions. So folks who are actively dying tend to get a lot of secretions in mouth or throat and so forth. You can treat these with anything that dries you out. Now, in the palliative care setting, we typically use atropine or glycopyrrolate or Rubinol for treating that. But if you're not carrying those things, then Benadryl may be worth considering as well, and suctioning the patient and clearing those secretions. Nobody wants to feel like they're drowning ever. but the other thing is those other PCC skills that we teach. Patting the patient well, making sure they're warm, top and bottom, doing that massage, the gentle range of motion, wetting their mouth, giving them a little, like if, we're probably not talking about somebody who's awake at this point. So, but, swabbing out their mouth, with, some, a little bit of mouthwash or water or something like that. These, things and, presence, emotional and physical presence, talking to the patient, all of these things. We talk about these skills in prolonged casualty care. We very rarely practice them, but take a holistic view of the patient's comfort and what you're doing for them. Not just like, I'm gonna kill everything with morphine. Like, okay, cool, but you may have a limited supply of drugs too, especially if you're a medic, that you've got what's in your pack. You're probably not carrying 12 grams of ketamine. And so you're going to have to make that, you're going to have to stretch that. So are there other things that we can add? Do we have acetaminophen? Do we have non-steroidals that we can use? Using the Benadryl, that helps to attenuate, or that helps to potentiate the analgesic effect of non-steroidals. So, I like to give a little Benadryl with or a little hydroxyzine with the Toradol. These other things, but the massage and stretching and other things can help reduce the need for the opioids in managing pain.
Yeah, absolutely. Just to kind of caveat, talking about respiratory rate, especially when you're talking about somebody who's unconscious, like that is an absolutely valid method to determine if you've actually achieved some kind of pain control, is they have a normal respiratory rate. So you're not making them die quicker. You're just doing good analgesia and sedation. Things like positioning, just getting the guy to sit up, that can help them clear their own secretions. That'll help them get to sit up and look around. It just makes people feel better. And it probably will make everybody else around them feel a little bit better about what's going on, because they can see while they're doing whatever it is they're doing. Hey, he's sitting up. I can keep an eye on him while I'm, whatever task they're doing. And just sitting there talking to him. As you go under anesthesia, your last sense to go is your sense of hearing. So just assume that they can hear you. Talk to them. Like, whether they respond back or not really doesn't matter. You're there for them. Just talk to them. Just talk about whatever. You don't have to talk about, the I'm sorries and things like that. Talk about whatever your last conversation was. Finish it off, because this might be your last opportunities, and give the other guys those opportunities as well. And we talk about like the medical aspects, like, washing the mouth out, etc. If the guy wants a dip, give it to him. Like there's, he wants to smoke, freaking send it. Like, whatever morally you're willing to do in this moment in time, like now's really your chance. Like, just let them have it. You're not worried about, this is bad for your health. Like, we've gotten beyond that. I don't think this is going to be the problem.
I need to do a study on the effects of Zins in combat casualty care.
Yeah. Generally it's always good. But at this moment in time, like, we don't care. We just want this guy to feel comfortable, to feel connected, and ease his passing. And that's what the patient wants. That's what everybody wants.
I agree. I have very recent patient experience with this. Just a couple days ago, a patient that I saw in shift who clotted his aorta and basically just clotted the circulation to both of his lower extremities, which was we could consider a salvage operation of bilateral above the knee amputations, but really this was not going to be survivable injury, and if it was, then he's looking at no legs and being in a nursing home the rest of his life, and really doubtful that he would even survive the surgeries regardless. But in talking with him, I just had a very frank discussion with him of this is what you're looking at, and this is where what your quality of life is looking at if you survive. And here's the doubt in that as well. But we have two options here. We can do all these resuscitative efforts and put you in the ICU, potentially operate on you and try to save you, and do these things. We don't think you're going to survive that. Or option B is we concentrate on your comfort, your anxiety. We're liberal with pain medicines. We're not worrying about your blood pressure and all of that. What do you think? And he said, I think I'll go with option B. And which I completely support. And so we're like, absolutely. I put in the orders for, look, morphine every 30 minutes as he needs it. Be generous with that, and with the Ativan orders and the Rubinol, and so. But what and then I chart checked him, and he died the following day, but I even read the notes from spiritual care and the nursing notes and so forth. But talking with the other nurses and resident and medical student that were taking care of him, we all felt really, really good about that care. So I think sometimes we avoid palliative care because we think that's going to feel terrible, but in fact, it's quite the opposite. All the times that I've been in that where we've helped the patient and they've made that decision to go that palliative care route, far from being traumatic, it in fact it's given us a great sense of worth in what we're doing, and helping somebody who's not going to survive meet that with dignity and comfort. The other piece is, you mentioned that trauma, the psychological trauma of the, man, what did I not do? So throw some expectant casualties, or throw some casualties in there that aren't going to survive no matter what you do. And every time I do that with these teams, these are all experienced medical providers. They're great at what they do. Surgeons, ER docs, soft medics, nurses, all these folks. And it goes hard. Like they have to sit with their feelings on it. And understandably, because they really feel the loss. And that's when you can have that discussion that survival is not the only good outcome that we are seeking. And to prepare for that in training as well, some of the good outcome is arriving at the decision and saying, yeah, okay, this is not, we're not going to burn all these resources on this casualty, all the resuscitation and blood resources, and do this. Just the fact that you were able to arrive at that decision is a plus, and is worthy of recognition in the training. So anybody who's doing these trainings for the medics, to avoid scarring them later, put some casualties in there that die no matter what you do, and let them in training get that feeling of futility, and that doubt and everything that's going to happen to you in real life when it happens, so that you can talk about it and come to terms with that and recognize that feeling. So when it does happen for real, you're like, okay, I recognize this feeling, but I also recognize that I'm good at what I do. And this was the outcome that was going to happen, and I'm okay with that.
Yeah. So, you mentioned, one, I know you're a provider and a very good doc. I know you've been around patients that have expired. You just mentioned one. I think it's one thing that which is great, that you were able to have the conversation and the patient decided this. When those times that you can't, you're just working and working and working and working, and like it's just not going anywhere, and the patient can't decide option B. I guess, what do you go through? What do you talk about to yourself so that you don't, Monday morning quarterback, like, oh, I should have, you know what I mean? Like, what do you go through, or how do you explain it to yourself, I guess?
That's a great question, and it's always great when we have patient buy-in, right? When they can express their goals and needs and desires, and when they can't. Medicine used to be very paternalistic, right? You say, this is what we're going to do, and this is what we're going to do it, and here we go. Then we swung this other direction to correctly, like, recognizing patient autonomy, that patients have a voice in this discussion. And I think maybe a little bit too far, to where, as medical providers, we become passive observers, and we just like, well, here's your choices, and we're leaving a layperson with doesn't have really a nuanced vision of what things are going to look like for them, trying to make that decision. And I want to see us swing back a little bit the other direction, because we're providers, we're taking care of the patient, but we're also advisors and teachers to the patient. And the patient is going to ask, okay, what do you recommend, or what would you do? And I think it is completely fine, and I think it's a good thing for a provider to have a recommendation, to say, well, I don't know you that well, but and what your values are, but based on what you've told me thus far, I believe that this is most consistent with what you've talked about. But what if the patient can't express that? And here's where, again, as the medical provider, you're the subject matter expert. And as we try not to impose our own values on the patient in this very, very important discussion, it's still, if the patient's not able to express them, then we have to make certain assumptions. And maybe we do it by speaking with people who are close to the patient and know them well enough to know what their values, expectations, desires are, and so forth. But at the same time, we do sometimes have to make that decision. And surgeons tend to be pretty good at this. Like if you come in with a thoracic aortic dissection from your aortic root to your femorals, and you've hacked off your renals, and you've hacked off all these various things, and you're like, oh yeah, take them to the operating room. The surgeon will say no. They're not going to survive this. It's not going to be a good outcome at all. And we're not going to just make them die with a big hole in their chest. That's not right. We don't tend to do that same thing in emergency medicine with resuscitations. I don't know why we don't, because you have a 95-year-old that comes in and out of hospital cardiac arrest. Like, there's not a good outcome from that. Like, it's there. So, but at the same time, we're like, well, we're just going to do everything until we reach some sort of predetermined point of futility. And I think that, we as the providers, when the patient can't express their needs, desires, etc., we have to make a judgment call on what's right for this patient in the absence of any other information there. And we tend to favor aggressive resuscitation, right? Like, there are people that live in terrible situations that still smile every day. And so, writing somebody off is certainly not the right answer for the sake of writing them off. And I wish I had a good answer for that. I think what I tell myself, even in my hospital, when we have to go this direction, is, look at the terrible thing that they were really looking at, and I don't want this like internet anecdote of somebody who survived to drive what I'm doing for so many other patients. And there may be a little bit of doubt, but my goal is, whatever that pathway is that we go, that we do it the best we possibly can. And having seen that too in MassCal, and then asked myself, okay, did I do the right thing for this patient? I had a MassCal a number of years ago that downrange, and as we're pulling patients out of this helicopter that had crashed, and a dozen people, and one of them had a non-survivable open head injury, brain matter leaking, still breathing at the time, but a clearly non-survivable injury. And I'm like, yeah, put him down over there. He's expectant. And then as we're moving those casualties around, somebody said, hey, sure, we want him right here, like right by all of his buddies. Oh, yeah, you're right. That's a good thing. You just move him around to the other side of the helicopter, and we'll create a morgue section there. But really didn't focus a whole lot on that palliative care at that time. And I felt later in this, as I've sat with it, thought, man, I sent that dude out to die alone in this field. Unfortunately, he wasn't ultimately, but it was interesting as more medical providers arrived at the scene of this. A bunch of PJs came and distributing them on these various casualties, and then like the last dude's like, hey, what can I do? I'm like, that guy over there, go give him some morphine. And he really wasn't happy with that at all. In fact, didn't do it because I think he had this expectation, like, cool, I'm going to save lives. I'm not going to like baby this person. I don't think he really appreciated that time just how important that was to do that. And I'm also glad that some of the surviving casualties, the ones that can still walk, went to be by him. So that again, that having that presence there. But that's one that sticks with me because, I not feeling necessarily that I had done everything for that palliative care. He wasn't going to survive, like, end of story. But, that's the part that bothers me, not the fact that he died, but the fact that we at the time, all these other casualties, we couldn't do everything that I would want to do with the palliative care for him to ease his suffering.
It's always tough, and this is always a downer conversation, but like, you can make things so much better for everybody involved if you can just educate yourself on, like, this is just an aspect of life. Just like training for delivering babies, that's another aspect of life. And just getting some experience, getting some kind of training, and just having the maturity to recognize that this is what it is, and we can start shifting gears. And this is my new course of treatment. Completely different goals, but treatment nonetheless. And, have a real positive outcome or impact on the situation for literally everybody that is concerned with this.
Well, in doing end-of-life care in any setting, I think as the medical provider, you are not just treating the patient, you are treating everyone around them. You're treating their loved ones. And so for the combat medic in this setting, you're not just treating that casualty, you're treating his teammates, the guys that and gals that love this person and are suffering through this. And your compassionate care of that casualty speaks volumes, but also your guidance for them in this setting of, talk with them. And here we're doing this to help the pain. We're doing this to help the breathing and so forth. That will mean so much to the teammates as well. And that gives them the understanding that you're not giving up. You're not writing him off. You are very aggressively, compassionately treating the casualty. We're just treating we're just not cutting holes in them to surgerize them.
Well, awesome, JR. I really appreciate you jumping on and ruining my day.
Well, hey, you know what? Refill your coffee cup, my friend, and then we'll go outside. And it's a tough topic, I know, but I'm so glad that you had me come here, and thanks for letting me come and talk it out with you.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast, out.